By the end of this video, you should know the basic epidemiology of pneumonia, factors associated with high risk of pneumonia, how to collect samples for suspected TB cases, about the pneumonia vaccine and how to ensure children are vaccinated, how to screen for TB, and how to notify on the NMC app. Assess the child for the severity of the pneumonia using the classification here. Pneumonia, fever, cough and rapid breathing, but no chest indrawing of the lower chest wall and no flaring of nostrils. Severe pneumonia, fever, cough, rapid breathing, chest indrawing and flaring nostrils or grunting. Count the breathing to determine if it's fast breathing. Use this age respiratory rate guide. Birth to 2 months, more than 60 breaths per minute. 2 to 12 months, more than 50 breaths per minute. 1 to 5 years, more than 40 breaths per minute. Assess the child for danger signs indicating urgent and immediate referral, including cyanosis, the lips may become blue because there is not enough oxygen in the blood, inability to drink if they are less than 2 months of age, impaired consciousness, and grunting. Initiate the antibiotic treatment immediately if pneumonia is confirmed after counting breaths. Amoxicillin, oral, 45 ml per kilogram per dose, 12 hourly for 5 days. Weigh the baby as the dose is calculated based on the weight of the child. Also, assess the child for possible signs of TB. Most children acquire tuberculosis from infected adults by inhalation. Malnourished, immunosuppressed children with HIV and AIDS and children under 5 years of age are at increased risk for pulmonary tuberculosis. Signs and symptoms also include unexplained weight loss or failure to thrive, unexplained fever for more than 2 weeks, chronic unremitting cough for more than 14 days. Referrals are urgent for all children with severe pneumonia, i.e. chest indrawing of the lower chest wall, flaring nostrils or cyanosis, and all children under 2 months of age. Non-urgent referrals are when there is inadequate response to treatment, children are coughing for more than 3 weeks to exclude other causes such as TB, foreign body aspiration or pertussis. Young children, babies and premature babies are especially vulnerable to infectious diseases like pneumonia and TB. Any child presenting with symptoms and signs suggestive of pulmonary TB is regarded as a case of TB if there is a chest X-ray suggestive of TB and/or a history of exposure to an infectious TB case and/or positive tuberculin skin test, TST, for instance MAN2, a positive expert MTB or RIF and/or smear microscopy and/or culture on early morning gastric aspirate or induced sputum confirms TB disease. Tuberculin skin test, TST, for example MAN2. A positive test, TST induration above 10 millimeters. A TST may be falsely negative in the presence of malnutrition, immunodeficiency, for example HIV and AIDS, immunosuppression, for example steroid therapy or cancer chemotherapy, or following overwhelming viral infection like measles or post-vaccination. In these circumstances, a TST induration of more than 5 millimeters may be regarded as positive. Frequently, the TST will be non-reactive in these cases. TB treatment should be considered despite a negative TST. The following may be evident on chest X-ray. Direct or indirect evidence of hilar or mediastinal adenopathy with or without parenchymal opacification and/or bronchopneumonia. General measures. Identify and treat the source case. Screen all contacts for TB infection. Monitor the nutritional status of the child to assess response to treatment. Consider TB chemoprophylaxis or isoniazid preventive therapy or IPT in all children exposed to a pulmonary TB contact through close contact with an infectious pulmonary TB case. If the child is re-exposed to a close contact, TB chemoprophylaxis must be repeated. Previous IPT does not protect the child against subsequent TB exposure or infection. Positive TST only applicable on the first occasion of a positive TST. Please note that TB chemoprophylaxis or IPT is only used in children under 5 years of age or children of any age who are HIV infected. Initiate treatment on diagnosis of TB and ensure that there is directly observed therapy, DOT. Short course and using fixed medicine combinations are recommended. Treatment should be given daily in both the intensive or initial phase and the continuation phases. Be diligent about filling in the lab request N1 form with as much information as possible. Ensure that the laboratory request form is correctly and completely filled in. Tick the required test on the request form. Please note, incomplete or incorrectly filled forms could result in the sample being rejected. It should be noted that TB is a Category 2 notifiable medical condition, or NMC, because it poses serious health risks to communities. Every doctor or nurse or healthcare provider in both the public and private health sectors who diagnoses a patient with any one of the NMC must report the case. Failure to report an NMC is a criminal offence. Any type of TB is a Category 2 NMC and must be reported through a written or electronic notification within 7 days of clinical or laboratory diagnosis, but preferably as soon as possible following diagnosis. Please watch the NMC video in this series. Although pneumonia and TB are common in South Africa, they are preventable and curable. However, a lot depends on how quickly they can be diagnosed and treated, as well as on the patient's adherence to prescribed medication. In order to control the spread of pneumonia and TB, communities must be educated about general good hygiene practices. Bacteria and viruses can also be spread to others through contact or touch or from surfaces. Washing hands with soap and water is important. Sneezing and coughing also spreads the viruses that cause pneumonia, so you should cough and sneeze into your sleeve or into a tissue that you then dispose of safely. When with other people, the patient should wear a mask that covers their nose and mouth, and meetings should take place outdoors or in well-ventilated areas. The vaccines in the Expanded Programme on Immunization, EPI, help to prevent pneumonia caused by Haemophilus influenzae type B, pneumococcus, measles, and pertussis. The pertussis or whooping cough vaccine is also being given to pregnant mothers to prevent whooping cough, which can be fatal in very young infants. Always check the Road to Health booklet to see if the childhood immunizations are up to date. Ensure that you administer any missing immunizations accordingly. The BCG vaccine, given at birth, can prevent severe TB in very young children. Additional vaccines, like the flu vaccine, also help to prevent pneumonia. Flu vaccines are available in the clinics for vulnerable population around April-May before the flu season starts. Maternal immunization during pregnancy for influenza and other diseases can help to prevent pneumonia in mothers and babies. Breastfeeding can help to protect babies because the mother's antibodies are transmitted to the infant through breast milk. Thank you for watching this video. Please remind your colleagues that all children should receive their immunizations and, if missed, should receive catch-up vaccines. Notifiable medical conditions need to be reported. TB screening is important. HIV testing is important, as are ARTs for all those testing HIV positive.